We have our last speaker of the session, a local expert, Professor Victor Musiime from the Department of Pediatrics here in Kampala, Uganda at Makerere University. He joins us with a wealth of experience which ranges from clinical teaching, from undergrad to postgraduate, as well as seeing patients in the pediatric clinic. Apart from his academic duties, he's also an investigator across several clinical trials, and his research interests include infectious diseases, child nutrition, gastroenterology, and other child health issues. Welcome.
Thank you very much. And it's good we are ending with adolescents because that means we are thinking about the future. So really, we are going to look at the consideration for adolescents with all these regimens that have been talked about earlier. And as a bit of a background, Michelle really went at great length of explaining many of these trials. But if I may recap some of the issues there, dual regimens have been tried among children as well. In the earlier 2000s, there were studies that were assessing dual regimens, especially dealing with the NRTI-based regimens. For example, you could have AZT3TC or ABC3TC. Now, when these were tried and compared with NRTI or PI-based regimens, these dual regimens were inferior virologically. So that probably put off some interest for a while in dual regimens. However, as you heard from Michelle, the recent studies that have been done among adults, especially on integrase inhibitor-based regimens, particularly DTG and 3TC, have shown non-inferiority virologically when compared to triple regimens. And also when you see from what Dr. Diaz has just presented, even the resistance development is quite slow. So these studies are really encouraging. And you heard about Gemini and 1 and 2 as well as Tango. These really encourage, and we feel probably there is something that we can look at and something that would be good for adolescents as well. We also heard about the long-acting injectable dual regimens, that is cabotegravir and rilpivirine. These have also shown non-inferiority virologically when you compare to triple oral ART regimens. And there are several studies that have been done along those lines, but mainly in adults. Now, we all know that adolescents, whereas some of them have participated in some of the adult trials, but in many cases they're excluded, even when the dosing regimens or the dosing recommendations are similar. There is very little data on dual therapy among adolescents. However, there are ongoing studies. Right now we have several studies that are going on. One is DANCE. I'll talk briefly about that one, as well as D3. D3 is a penta trial, penta 21, and LATA, which is on long-acting treatment antiretroviral therapy. Now, the DANCE study, which I'm going to go a little more detail about, deals with safety, efficacy of dolutegravir and lamivudine in those adolescents who are treatment naive and they are infected with HIV-1. So they are naive. I think that's very, very important to note. And the primary objective of this study is to assess the antiviral activity of DTG and 3TC in these adolescents. There are some secondary objectives. One is to evaluate the immunological response to these drugs. Remember, these are naive. And then we'll also assess the safety and tolerability of DTG and 3TC, and also assess DTG and 3TC exposures and evaluate the safety, the steady state PK, and also assess the development of viral resistance while on DTG and 3TC in participants who may be experiencing protocol-defined virologic failure. So whereas the failures may be few, but there are some where the resistance goes probably, in this case, they're considering above 200 copies per mil. In fact, above 50. When that develops, then they go ahead and do some virologic, some resistance testing. So this is the design of DANCE. As you see up there, it's a single arm trial. So get the pointer. The participants are followed up for 144 weeks, and the participants that are included are those who are ART naive. They are over 12 and less than 18 years. Their viral load should be between 1,000 and 500,000. I think Francois talked about really the limitations of viral loads above that. And then the weight over 40 kilograms. And this is kind of like a pilot study because it's looking at only 30 participants. So the participants are being followed up for 144 weeks, and the primary analysis is at week 144. The primary endpoint, as you remember, is on virologic outcomes. We want to see what proportion will have viral loads less than 50 copies per mil. I'm aware that this study has fully enrolled the participants, and many of the participants are being followed up, and we should be getting some results quite soon. So it's encouraging that this study has been done among a naive population, so we see what would come in. What are the safety and, for example, even the dosing requirements, whether this is really adequate and whether they can adhere to it and whether resistance is really developing. So it's very important for us to go through this. So the setting is, this study is sponsored by VIV, and there are 12 sites. That means there's a lot of follow-up on these participants because there are only 30. The participating countries are Kenya, South Africa, Thailand, and the US. And hopefully, when we get the results, we'll learn from that. And that probably will give us some confidence to see if, for example, it is probably carry out a larger study and probably consider that adolescents could also start ART with a dual regimen. And why would it be important to start a dual regimen? This is because adolescents have a life ahead of them. They have to deal with resistance, and as well as deal with adherence to their medications. They have to deal with toxicities all through their lives. And they have to lead lives that will lead them into event-free adulthood, where they are safe and everything. So it's important that when they are starting, maybe you start with few drugs, have less toxicity exposed to them, and maybe have long-term outcomes as adults, where they will have living with HIV, but with no virus detectable, but at the same time, having been exposed to less side effects. Now, that was on a naive population. What about in an experienced population? D3 is a PETA 21 study, as I said. It is a randomized non-inferiority trial with some pharmacokinetic studies that are nested within there on DTG, 3TC fixed dose formulations for the maintenance of virologic suppression. So this considers those who are virologically suppressed and then kind of given a simplified regimen of 2 drugs. And this will be in children 2 to 15 years, meaning they will be suppressed. And then after that, they are kind of like simplifying their treatment, exposing them to less drug, and probably exposing them to less toxicities, and probably have good long-term outcomes. That's the design behind it. And what are the objectives of this study? This is really non-inferiority. We want to see whether DTG and 3TC given to these adolescents who are suppressed is non-inferior to the standard 3-drug regimen that we know in terms of viral suppression. The secondary endpoints include clinical and laboratory adverse events. It also includes identifying resistance mutations in participants with viral rebound, and also assessing low viremia and viral reservoirs. Prof. Diaz has just talked about this, because these adolescents, remember, have a lot of, very many years ahead of them. So if they have low replicating viremia and accumulation of resistance over time, that probably may have a buildup of immune activation over time that will lead to a breakdown in the immune system if that is not checked in time. So it's important that even those with low viremia are studied, and if there are any viral reservoirs or resistance mutations that are building up, that is also important to study. We'll also evaluate adherence, tolerability, acceptability, sleep, as well as health-related quality of life. And there are models to evaluate the PK and pharmacodynamics of some really dispersible and film-coated fixed-dose combinations. These have been evaluated in another study called Odyssey, but a more in-depth look at this will probably lead to better predictability of the doses than what we have, because many of the doses are modeled around the WHO weight bands, whereas Odyssey showed that these are adequate, but a more in-depth looking at this will also be quite good, especially in the context of using dual regimens. If the DTG3TC is shown to be non-inferior, then it's important to know whether it's cost-effective. So there will also be a study to evaluate the cost-effectiveness of this approach of using a dual regimen when compared to the 3-drug regimen. So this is the design of D3. D3, as I talked about, is recruiting children who are 2 to 15 years who are virologically suppressed. They're targeting 370 of them, and they will be randomized. Let me see if the pointer can come up here, okay? So they will be randomized in a 1-to-1 ratio to either have DTG and 2 NRTIs, which is the standard and the control arm, or to receive DTG and 3TC. And these will be followed up for an equal period of time. The follow-up is until 96 weeks. And the primary outcome measure, as mentioned earlier, is having virologic failure, where the virologic failure will be defined as having over 50 copies per mil, and the two will be compared. There will be some division, some comparisons at week 4, week 12, and then 12 weekly after. But the primary one is the one that will have happened at around by 96 weeks. So the analysis will be longitudinal. And then there are some PK studies that will be done, intensive PK and PD with full curves at steady state using the weight bands that are determined by WHO. And there will also be some sparse PKs determined using population PKs using sparse PK samples. So the setting is a PENTA study, like where PENTA stands for Pediatric European Network for Treatment of AIDS, whereas there's European in it, but this is now a global network. The coordinating centers, PHPT, which is in Thailand, as well as MRCCTU at UCL. The participating sites are in South Africa, Spain, Thailand, Uganda, and UK. There are other studies that are looking in depth, like I talked about the PK, the cost effectiveness. All these will be done by institutions in Netherlands and in UK. So then what about the long-acting injectable drugs? Now, we've had challenges with the adherence, and Dr. Sally talked a bit about it in the morning with adolescents. This will particularly be more interest to us as pediatricians who are looking after adolescents than maybe in the adult trials, because we really have several adolescents struggling with taking drugs every day. And whenever we mention this, even when press reports came about, Dr. Venter showed a press release. We had a similar one here where people were talking about injectable drugs being a possibility in our setting. We got several calls. When am I going? When will I get this? When will this happen? So there's a lot of interest in the long-acting injectable drugs. It's the same drugs that are being used, cabotegravir and rilpivirine. So this will be in biologically suppressed adolescents aged 12 to 19 years, and still within our region here in sub-Saharan Africa. So the objective is to look at virologic efficacy, the safety, acceptability, and quality of life of these drugs, cabotegravir and rilpivirine, when compared to daily therapy with the triple oral ART that is DTG containing. So it's a DTG comparison. They're comparing cabotegravir and rilpivirine with a DTG containing regimen among adolescents. So this is the design. It's still a randomization of 1-to-1. Let me get my pointer here. So equally, and the interesting bit here is that in addition to looking at, in this 3-drug regimen, at looking at DTG with the other drugs, there is an opportunity to compare between TAF and TDF, and also an opportunity to compare FTC with 3TC in this regimen. So that, I think, is something very valuable, especially when you're thinking about TAF and TDF with the adolescents, because you are really concerned about safety. It's concerned about their exposure to these drugs for a long time. So this comparison is of very much interest to us, as well as the comparison. The standard arm is the same. It's the cabotegravir rilpivirine, that is the intervention arm. Follow-up is until 96 weeks, and the primary outcome is confirmed viral load by week 96. And the same approach of looking at the issues around. Here we're very much interested in the social science. How are the adolescents feeling about this? How is the quality of life? How is it affecting their programs? They are going to school, they are going out, and all the other things that they may be interested in, because those are very important. Neuropsychiatric events. How is it affecting their schooling? How is it affecting their sleep and ability to stay up at night? Metabolic events, very important, especially among the adolescent girls. Adult studies have seen some pointers towards weight gain. This is very, very important. Health economics, the cost effectiveness of the injections. Francois talked about the cost of the injections. Will this apply when you consider other things like transport costs to the facilities and all the other things? Does it apply? Does it help? The pharmacology around this, whereas there have been some studies in adults, adolescents may have, or especially the younger children, because the closer they are to 12, the issue of puberty and them growing and the rest, does it have any effect on the drug levels? That's all important for us to assess. So the setting, the sponsor is University College London, the coordinating center is MRCCTU at UCL, the participating countries are Kenya, South Africa, Uganda, and Zimbabwe. And the ancillary studies or the sub-studies, especially PK and all the others, the social science, are being done by institutions in Netherlands and UK, as well as Penta. Now, the issue of Penta comes in with looking at the community groups. We have a group of what we call advisory boards. What is the issue? What are their views? How do they participate in research? And what are their views? And what what information do they get when they relate with their peers about this? So this is something that we want to study systematically and see whether there's any information that would be of use when implementing this strategy, because we hope that it will be one of the options that will be on the table. So in summary, we all know that adolescents, I'll repeat this because it's important. Adolescents have very many years ahead of them. They need to grow into adults that are free of ailments, free of side effects, free of toxicities, in good mental state, in good physical bodies that they can live with to adulthood. Now, we need to come up with regimens that are convenient for them to take. For example, it should be once daily. And if they're once daily, do they remain safe? If you are removing drugs and having less drugs in the combination, do they remain efficacious? So all these are important considerations to make. Adult studies are encouraging that this will work. So we have an opportunity with the studies that I've mentioned, whether it is dance or D3 or LATA, to evaluate this. We think we are positive. Our hypothesis is that these drugs will be options and they will be safe and efficacious. So this will be an opportunity to look at this. And the end result, as I mentioned earlier, is to ensure that the quality of these adolescents as adults is good. So I want to thank the various study teams, DANCE, D3, and LATA, for the information that I've provided here, and also the organizers of this forum for the opportunity to present here. Thank you very much.